Hello everyone, very good evening to all. Welcome you all to this NEET MDS recall session in Physiology 2024 exam. Hope all of you are really exhausted after your exams. So quickly let's go through the questions that were asked from Physiology. Overall, it was a moderate to a bit tough of paper, but a moderate kind of paper. From Physiology as such, the questions that were asked from Physiology, very basic type of questions. If you had properly attended all the classes, taken proper notes, definitely like that you will be able to solve Physiology questions. Very simple basic questions. And we had also few clinical based scenarios. Let's discuss all that. Let's start with the first question in Physiology. That was a clinical case discussion. A 19-year-old boy came to the OPD after a road traffic accident with inability to speak. The doctors think of injury to Broca's area. In which of these lobes is Broca's area located? Very simple question from speech physiology. So let's learn that. First, let me show you what are the areas for speech or the language areas of the brain. What are the language areas of the brain? Broca's area and Wernicke's area, two major areas responsible for speech. Broca's area. Look at the location of Broca's area. This is the frontal lobe. Broca's area is this. So it is located on the inferior part of the frontal lobe. This one. Inferior part of the frontal lobe. Broca's area. Brodmann's number 44 and 45. Wernicke's area. Look at the location of Wernicke's area. This is the temporal part, the temporal lobe. This is Wernicke's area. Wernicke's area is located on the superior part of the temporal lobe. So Broca's area and Wernicke's area. Broca's area is on top and Wernicke's area is down. So likewise, we can remember the blood supply of Broca's and Wernicke's also. Broca's area, since it is on top, it's on the frontal lobe on top, this is supplied by superior branch of middle cerebral artery. And Wernicke's area, Brodmann's number 22, this is located on the temporal gyrus, the temporal lobe. It's down, it's inferior, right? Broca's is on top, Wernicke's is down, it's inferior. So Wernicke's area, this is supplied by inferior branch of middle cerebral artery. Superior branch superiorly to the Broca's. Inferior branch inferiorly to the Wernicke's area. So that was about Broca's area and Wernicke's area. Let's see the differences between Broca's and Wernicke's. Any damage to Wernicke's area results in Wernicke's aphasia, and any damage to Broca's area results in Broca's aphasia. What are the differences between Wernicke's aphasia and Broca's aphasia? First of all, what is aphasia? It's a language disorder. It's a speech disorder. If the patient has any damage to language areas of the brain and therefore he is not able to speak, this is called aphasia. Let's say there's a patient who has a mouth ulcer. There's an injury to the mouth. There's a mouth ulcer and therefore he is not able to speak. Can I call he is suffering from aphasia? No, this is not aphasia. Aphasia is any damage to the language areas of the brain, speech areas of the brain, either Broca's or Wernicke's. If there is any damage to the speech areas of the brain and therefore the patient is not able to speak, only that we call it as aphasia. If you have any ulcer in your mouth or lip, any injury to your lips or tongue, or there's any cut of the tongue, and therefore the patient is not able to speak, that is not called aphasia. It is related to your brain areas of speech. The differences between Wernicke's aphasia and Broca's aphasia. Wernicke's area, area number 22. Any damage to Wernicke's area, Brodmann's number 22 results in Wernicke's aphasia. What is the location of Wernicke's area? Posterior end of superior temporal gyrus. It is in the posterior end of superior temporal. So it's on the temporal lobe. Wernicke's area is the sensory area for speech because Vernix area senses the meaning of words. It is responsible for comprehension of words. It helps in comprehension. It is receiving the word first. So if you talk anything to any person, the first area which is able to receive the word is Vernix area, and it is able to understand the meaning, to sense the meaning of the word. So that is why any damage to Vernix area results in sensory aphasia. Comprehension is lost. In Vernix aphasia patients, Vernix area responsible for comprehension. So if there is any damage to the Vernix area, comprehension is lost. Fluency is not lost. Comprehension is lost, but fluency is not lost. That is why this aphasia is called as fluent aphasia. So when you talk to this patient, Vernix aphasia patient, he will not be able to understand whatever you speak because comprehension is lost. But fluency is not lost. So fluently he will speak. So his speech is called meaningless. Why it is meaningless? Because he is not able to understand. Vernix area is affected, comprehension is affected. So it's meaningless. But fluency is not affected. So it is fluent. So this is called a meaningless fluent aphasia. So whatever you talk to this patient, he is not able to understand because it is a meaningless. Vernix area is affected, but he will talk fluently. Let's say there is this phrase, any phrase. Let's say Betty bought some butter. The butter was so bitter. Betty bought some more better butter to make the bitter butter better butter. You ask this Vernix aphasia patient to say this phrase. You know how he will say? Whatever you said, he didn't understand, meaningless. But he wants to speak fluently. He'll say something fluently. He will say like this, Betty, 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 Betty. See, he is not able to understand the meaning, but he wants to say something fluently. So without meaning, he will keep blabbering something. This is called Vernix aphasia. So when he is talking like this, there's no meaning. So he is creating his own new words. That is called neologism. New words. He will create his own new words but without any meaning. One severe form of Vernix aphasia is jargon aphasia, where the patient is in his own word. Whatever you talk, he won't be able to understand. Whatever he is saying, you won't be able to understand. So you cannot communicate to this patient. That's called jargon aphasia, one severe form of Vernix aphasia. Over to Broca's aphasia, damage to area 44. Where is Broca's area? Inferior frontal gyrus. So it is on the frontal lobe. Broca's area, motor area for speech, helps to produce speech because Broca's area has connection to motor cortex. From motor cortex, you have impulses to the speech. So to your speaking muscles, the speech muscles, and that is how we speak. So it helps to express the word. You're speaking the word. You're expressing. So it is called expressive aphasia or motor aphasia. Comprehension is not lost. So comprehension is fine because Vernix is not affected. Comprehension is fine. Broca's is for fluency. Fluency is lost. So this speech is, his comprehension is not lost because Vernix is fine. Meaningful. Whatever you say, he'll understand. But his fluency is lost. So this is called a meaningful. He's able to understand the meaning. So it is meaningful but non-fluent speech. Meaningful non-fluent speech. This is Broca's aphasia. Meaningful but non-fluent speech. So Vernix aphasia and Broca's aphasia. If you ask Broca's aphasia patient to say this, Betty bought some butter. The butter was so bitter. Betty bought some more better butter to make the bitter butter better butter. You ask him to say this, he'll understand everything. Meaningful. He understood your meaning, but he is not able to speak fluently. This is a meaningful non-fluent speech. So how he will say this? He understood everything. So he'll try to say the correct one only, but without fluency. He will say Betty, bought. See, this is a stammering or stuttering speech. One cause for stammering or stuttering speech is Broca's aphasia. So that is about Vernix aphasia and Broca's aphasia. Over to the question. There is any damage to Broca's area. Where is Broca's area located? Yes, on the inferior frontal gyrus. It is on your frontal lobe. Over to question number 2. A 13-year-old child goes to the ophthalmologist with complaints that she is unable to read the blackboard. So blackboard is far apart. She is not able to read that. but could read books near to her. So near objects she is able to read. If you keep a book close, she is able to read, but she is not able to read the board. What is this defect called as? Unable to read far objects but able to read near ones. Myopia and hypermetropia, two different conditions related to refractive errors of the eye. What is myopia? Myopia is also referred to as short-sightedness. In myopia, nearby objects are clearly seen but not the distant objects. See what the child is suffering from. Nearby book she is able to read, but distant object she is not able to read. So this is myopia. The features for myopia, also called short-sightedness, also called as short-sightedness. Near objects clearly seen, far object, distant object not able to see. For the people with this defect, image is formed in front of retina. If the image is formed in front of retina, it means the curvature of the lens is more. So this is due to excessive curvature of the lens. Since your curvature is more, object is not able to reach retina. It is falling in front of retina. But it can be easily corrected by using a concave lens. To bring the object to exact position on the retina, you can use a concave lens. So this is a myopia defect. Exactly the object should fall here on the retina, but it is falling in front of the retina. Myopia. Hypermetropia. What is hypermetropia? Exactly opposite defect. Long-sightedness or hypermetropia or hyperopia. Far objects are clearly seen, but nearby objects you cannot see. Exactly opposite. So the image is formed behind the retina. It goes behind the retina. This becomes when focal length of the eye becomes too long. This might be easily corrected by using a convex lens. So this is hypermetropia, where the image should fall on the retina, but it is falling beyond the retina. Beyond the retina. Hyperopia or hypermetropia. So in this question, the child is not able to read the blackboard which is at a distance, but he is able to read book which is kept closer. So this is short-sightedness, myopia. Question number 3. True about cell membrane layer. The cell membrane layer is a lipid layer fat soluble, protein bilayer water soluble, protein bilayer fat soluble, or lipid bilayer water soluble. The answer is very easy question. It's a lipid bilayer fat soluble. Fat soluble lipid, because if it has lipids in the layer, it's only fat soluble substances can pass through this membrane. The cell membrane composition. Cell membrane is made up of 55% proteins, 40% lipids, and only 5% carbohydrates. This is the composition of any normal cell membrane. But there is one membrane which has lipids of 80% and protein content 20%. The lipids are more than the proteins. So it is an insulating membrane. Which is the insulating membrane? Myelin membrane. Myelin is the insulator. Myelin is the insulating membrane. And that is how myelin becomes an insulator. Myelin is the layer around the axon of the nerve fiber. What are all? The composition of the cell membrane, proteins, lipids, and carbohydrates. Who proposed this model? The model is called fluid mosaic model. Fluid mosaic model, which is a lipid bilayer model. If it is a lipid bilayer, definitely it should be fat soluble. So it is a fat soluble lipid bilayer. And we can also have a look at all the components of this cell membrane. Cell membrane has proteins and lipids. What are all the proteins? The proteins are integral proteins and peripheral proteins. What are the integral proteins? They act as receptors, channels, and carrier proteins. Peripheral proteins are, especially on RBCs, you have spectrin, ankyrin, band 3. In muscles, we have dystrophin protein. What are the lipids? Phospholipids, glycolipids, cholesterol. What are the phospholipids? Present outside the cell membrane and inside the cell membrane. Outside the cell membrane, the phospholipids are phosphatidylcholine and sphingomyelin. Inside the cell membrane, phosphatidylserine, phosphatidylиnositol and phosphatidylglycerol, cardiolipids, glycolipids, gangliosides and cerebrocytes, and we also have cholesterol. All these are the composition of the cell membrane. Back to the question. True about cell membrane layer. Yes, it is a lipid bilayer, fat soluble. Over to question number 4. The enzyme present in saliva. Saliva has various enzymes for digesting various substances, but always the most important enzyme in the saliva is amylase. The primary enzyme in saliva is amylase. Let's have a quick look at the digestion of carbohydrates, proteins and fats and just the role of these enzymes. First, digestion of carbohydrates. Carbohydrate digestion begins in the mouth, saliva, by the action of salivary alpha amylase. The optimal pH for this action is 6.7. So the salivary amylase plays an important role in carbohydrate digestion. In stomach, there is no enzyme for carbohydrate digestion. In pancreas, you have pancreatic alpha amylase. The end product of alpha amylase digestion is, because of the action of pancreatic juice, the alpha amylase, the end product here is oligosaccharides. Oligosaccharides, when they enter into your small intestine, by the action of enzymes in the small intestine, isomaltase, maltase, sucrase and lactase, the end product in the small intestine is monosaccharides. What are the monosaccharides? Glucose and fructose. This is how carbohydrates are digested. So there is alpha amylase in the saliva, which plays an important role in carbohydrate digestion. What is the fate of these carbohydrates? Glucose and fructose. How is this absorbed? In the small intestine, monosaccharides, glucose and fructose are formed. What is the fate of this glucose and fructose? Glucose and fructose. Glucose, with the help of SGLT1, is absorbed in the intestines. On the other side, through GLUT2 transporter enters into the blood. What is SGLT? Sodium glucose cotransporter is SGLT. Sodium along with glucose. So when you give sodium along with glucose, SGLT1 activity is very rapid. Quickly it will absorb glucose through this channel. On the other side, through GLUT2, this is a facilitated type of diffusion. SGLT is secondary active transport. GLUT2 is facilitated diffusion. Fructose, with the help of GLUT5 on one side, it is absorbed on the apical membrane of the intestinal cells. Fructose is absorbed by GLUT5 and on the other side, basolateral side, through GLUT2 enters into the blood. So this is the fate of carbohydrates and how they are digested. ORS, what is the clinical significance of this? SGLT1. ORS packets, oral rehydration solution, contains sodium along with glucose. Why do you, that was a question, previous year question, why do you combine salt along with sugar in ORS packets? Because when you want to replace the electrolytes, only if you give electrolytes, sodium absorption is slow. But when you combine sodium with glucose, this activates SGLT1 and SGLT1 quickly absorbs salt along with glucose into the intestine. So if you want to enhance salt absorption, you can give it along with glucose. That is the clinical importance of this SGLT1. Digestion of proteins. In saliva, there is no enzyme for protein digestion. In stomach, pepsinogen is converted to pepsin by the action of gastric acid. In pancreas, pancreas has pancreatic juice. The action of pancreatic juice contains several enzymes, enterokinase, by which trypsinogen is converted to trypsin. And trypsin can convert again trypsinogen into trypsin, and chymotrypsinogen is converted into chymotrypsin. Proelastase is converted to elastase. Procarboxypeptidase is converted to carboxypeptidase A, and procarboxypeptidase B is converted to carboxypeptidase B. Therefore, polypeptides are converted to di and tripeptides. This is the digestion of protein. So for protein digestion, there is no enzyme in the saliva. Lipid digestion. In mouth, von Ebner's gland, they produce lingual lipase. And lingual lipase has a very small role in digestion of lipids. This is not as important as amylase. So when you compare amylase and lipase, amylase only is the most important substance. And also this lingual lipase does not come from other salivary glands. It comes only from von Ebner's glands. In the stomach, gastric lipase. In your pancreas, the enzymes are pancreatic lipase, co-lipase, cholesterol esterase, by which triglycerides are converted to free fatty acids. And they enter into the small intestine. What is the fate of these free fatty acids in the small intestine? Bile. The role of bile. Bile emulsifies fat by forming missile-like substances. This is called detergent action. They form missile-like structures, and this is absorbed by the intestinal cells by passive diffusion. This is a missile, and missiles help in digestion and absorption of fats. In the intestinal cells, what is the fate of this free fatty acid? Free fatty acid re-esterified into triglycerides, and they form chylomicrons and thereby move into the lymphatics. By exocytosis, they enter into the lymphatics. This is the digestion of carbohydrates, proteins and fats. Over to the question. The most important enzyme present in saliva, amylase. Even though you have lipase, lipase comes only from von Ebner's gland, not actually from the major salivary glands, but from von Ebner's glands. And anyways, amylase only is the most important enzyme, so we'll go with amylase. Question number 5. Ataxia in walking with intentional tremors is seen in lesions of, yes, cerebellum. What is the role of cerebellum? Cerebellum has 3 major parts. Look at the location of cerebellum. It is somewhere here. Can I show the location like this? Yes, somewhere here. It is in between your motor cortex and all parts of the body below, because the cerebellum, it is located here in the posterior part. It receives the planning for the motor movements from the motor cortex and receives all movements from all parts of the body from below. From above it gets the plan from the cortex, from below it gets the movements, and cerebellum coordinates the plan with the movement. And that is why cerebellum is called as the coordinator of the body. Coordinator of the body. And that is why any damage to cerebellum results in incoordination. The term given for incoordination is ataxia. So ataxia is seen in diseases of cerebellum. Quickly, let's go through the parts of the cerebellum and the related clinical importance. Cerebellum has cerebrocerebellum, vestibulocerebellum and spinocerebellum. 3 parts of the cerebellum: cerebrocerebellum, vestibulocerebellum and spinocerebellum. What is the role of cerebrocerebellum? Helps in planning of movements. Vestibulocerebellum helps in equilibrium. Spinocerebellum helps in coordination. That is why if you have any damage to the cerebrocerebellum, planning is affected. If planning is affected, then there is delay in initiating movement. So any damage to cerebrocerebellum, there is delay in initiating movements. Vestibulocerebellum, vestibular apparatus means balance and equilibrium. So any damage to vestibulocerebellum results in disequilibrium and nystagmus. What is nystagmus? Eyeball disorder. If you try to fix your eyeball on an object, it is not fixing, it is oscillating. Spinocerebellum helps in coordination, and that is why if you have any damage to the spinocerebellum, coordination is lost, and this results in incoordination. The term given for incoordination is ataxia. What are the different types of ataxia? Or what are the different types of incoordination? Incoordination of speech is called dysarthria. Incoordination of distance is called dysmetria or past pointing. What is dysmetria? Meter. Meter means distance or length. Dysmetria is when you ask a patient of cerebellar disease, let's say there is a pencil here, you ask him to pick up this pencil. He cannot measure exactly at what distance the pencil is. That is dysmetria. He is not able to record distance. So his hands will go forward, it will come back. go forward, come back. Exactly, he cannot pick up this pencil. This is called past pointing. He is pointing past the object, past pointing. This is called dysmetria. If you do like this continuously, you will have tremors, and that is called intentional tremor. Intentionally, when the patient wants to do an activity, there is tremor. This is called intentional tremor. This is in contrast to resting tremors in Parkinsonism. Parkinsonism is a basal ganglia disease where you have resting tremor. But intentional tremor is seen in cerebellar disease. Intentional tremors. Incoordination in doing alternate movements. This is called dysdiadochokinesia. You ask the patient to do like this, alternate movements. He can't do. He will only do like this. This is called dysdiadochokinesia. Incoordination in stopping a movement, rebound phenomena. You ask the patient to flex his hands like this and you give resistance in the opposite direction. Suddenly, if you remove your hands, he'll go hit on his face. This is called rebound phenomena. This is how you will check for the cerebellum functions, and these are all the disorders related to the cerebellum. So the ataxia and intentional tremors are seen in lesions of, yes, cerebellum, cerebellar disorders. Question number 6. A patient has injury to posterolateral part of the spinal cord. Which of the following is true regarding his clinical examination? Posterior part of the spinal cord has dorsal column fibers. The first thing is, when there is any injury to the posterolateral part, posterior means the dorsal column fibers are in the posterior. So his dorsal column has been affected. In dorsal column, the dorsal column fibers, there are two types of dorsal column fibers. Fasciculus cuneatus and fasciculus gracilis. Fasciculus cuneatus and fasciculus gracilis. These are the two fibers, two tracts which form the dorsal column. Fasciculus gracilis runs medially in the spinal cord. Medially means towards the center. It runs medially and is responsible for carrying sensations from lower limbs. Fasciculus cuneatus, this runs laterally in the spinal cord. Laterally means away from the center. More towards medially is fasciculus gracilis, laterally is fasciculus cuneatus. This carries sensations from upper limbs. So if there is any damage to the posterolateral, posteriorly you have dorsal column, laterally there is cuneatus. So the patient will lose his dorsal column sensations in his upper limb because upper limb runs laterally in the dorsal column. If there is any damage to the medial fibers, then it would result in loss of dorsal column sensations in the lower limb. So in the question given, posterolateral part of the spinal cord, posteriorly dorsal column, lateral part you have your upper limbs. So there is loss of dorsal column sensation in the upper limb, and preferably the dorsal column sensation from the option is not pain, because pain is carried by spinothalamic tract. It should be proprioception. So it is ipsilateral or contralateral. Let's trace the dorsal column fibers. So the dorsal column fibers from one half of the body, if this is the spinal cord and this is medulla and this is the sensory cortex, right side and the left side, the sensory cortex. The dorsal column fibers, they enter into the spinal cord, they ascend on the same side. In the medulla, the fibers cross to the opposite side and reach the cortex. So this is the dorsal column fiber. The dorsal column tracts. So if there is any damage to this dorsal column fiber, the patient will lose sensations on this half of the body. So it is the ipsilateral, same half of the body, because dorsal column fibers don't cross in the spinal cord. They ascend on the same side. They cross only in the medulla to the opposite side. So if you have any damage to the dorsal column fibers in the spinal cord on this side, on the same side, patient will lose his dorsal column sensation. So it is ipsilateral. So the answer would be ipsilateral loss of dorsal column sensation. Which is the dorsal column sensation given in the option? Proprioception. Pain is not a dorsal column sensation and it is not contralateral, it is ipsilateral. So the answer is option A. He will lose his proprioception on the same half of the body. Ipsilateral loss of proprioception. Over to question number 7. Calculate the cardiac output with the given data. What was the given data? End systolic volume, end diastolic volume and heart rate. End diastolic volume of 120 ml and end systolic volume of 70 ml. What is stroke volume? Stroke volume means end diastolic volume minus end systolic volume. How much the heart is filled with blood, end diastolic volume. Out of that, how much has been moved out? That is stroke volume. So if you subtract end diastolic volume and end systolic volume, you will know how much has moved out. That is called stroke volume. Every stroke of the heart, how much of blood moves out? That is called stroke volume. So if you subtract this, 120 minus 70, you get 50 ml of stroke volume. What is the formula to calculate cardiac output? Heart rate into stroke volume. Heart rate of 70, stroke volume of 50. So this is 3.5 liters per minute. So in this question, the answer is 3.5 liters per minute. 3.5 liter per minute. So using this formula, cardiac output is equal to heart rate into stroke volume. Question number 8. Valerian degeneration occurs in which of the following? So this occurs in your nerves. In nerves, we learn about Valerian degeneration. If this is a neuron, if there is any injury to this neuron at this level, there is some injury at this level. So this segment which is closer to the cell body, this becomes the proximal segment. And proximal segment, since it is close to the cell body can provide enzymes, proteins, growth factors, and therefore proximal segment can easily go for regeneration. This is called proximal regeneration. The distal segment, this segment which is away from the center, away from the cell body, distance from the cell body. So this is called the distal segment. Since it is away from the cell body, there's nobody to give proteins, enzymes and all, because cell body only has to provide all this. So the distal segment always goes for degeneration, and this was discovered by Waller. So it is called Valerian degeneration, and degeneration starts within 24 hours of injury, whereas regeneration may take around 48 hours from injury. So this is distal degeneration called Valerian degeneration, which happens in your neurons, the nerves. Over to question number 9. Which of the following is true regarding cardiac markers for myocardial infarction? First, let's quickly learn about the markers for myocardial infarction. There are certain enzymes and proteins called cardiac biomarkers. They can leak into the circulation from the damaged myocardial cells. If a patient undergoes myocardial infarction, heart attacks, so this cardiomarkers, the biocardiomarkers, they can leak into the myocardial. They are leaking into the circulation from your damaged myocardial cells. What are all the cardiac biomarkers? Troponin T and troponin I, creatinine kinase, lipoprotein A, lactate dehydrogenase, LDH, and homocysteine. Troponin T. This troponin T is a cardiac specific marker released 2 to 4 hours after myocardial infarction. This is the most specific marker also, troponin. Peak levels are seen after 12 hours and persist up to 7 days. These are the most sensitive and most specific for myocardial infarction. So the most important biomarker is troponin. What about CK, creatinine kinase? The levels increase within 4 to 6 hours of myocardial infarction and last for 2 to 3 days also. It is relatively specific when skeletal muscle damage is not present. So when you take creatinine kinase values, lab reports, you should make sure that there is no damage to skeletal muscle, because skeletal muscles also can release this creatinine kinase. Lipoprotein A. There is a relation between atherosclerosis and circulating levels of lipoprotein A. It interferes with fibrinolysis by decreasing plasmin generation. So this can affect your plasmin levels. Lactate dehydrogenase. Levels peak within 72 hours, but this is not as specific as troponin. Troponin only is the most specific marker. Homocysteine. This substance damages endothelial cells of coronary vessels. There is a strong positive correlation of circulatory levels of homocysteine 1 and myocardial infarction. So from this, we understand that LDH is a better marker for troponin. This is wrong, because troponin only is the most specific marker, and LDH is an isoenzyme. Yes, LDH is an isoenzyme. This is correct. So which of the following is correct? Option B is right. LDH is an isoenzyme. So that was a quick learning of NEET MDS 2024 questions. Very basic questions from physiology. If you have attended all my physiology classes properly, and if you had taken proper notes, definitely we have already solved all these questions. So with that, we complete our session. And a word about our Advanced Plus version of our MDS app. So please subscribe to our Advanced Plus, and you will definitely enjoy all the benefits of this. There are pre-recorded videos, 600 plus hours of recently recorded updated videos, an extensive question bank with more than 20,000 exam relevant high yield questions, and we also have a good collection of explanations for all the questions, and competitive test series with 19 subject wise and 1 image based test, 12 grand tests, and multiple mock and also mini tests. And you can explore our clinical world, where we have 40 hours of clinical videos with a special focus on doctor-patient interaction also. And you can also get a carefully crafted high-quality timestamp notes for all the 19 subjects. And there are also revision videos that are available, and special sessions by Dr. Himani for our daily mentorship program. So don't settle for less when we are there to provide you with more quality of education. So this is Dr. Abirami wishing you all very happy results for all your efforts that you had put. So awaiting very positive results from your side. So thank you so much. So in case we have any other questions or any other comments or questions or options that are changed, because this is only a recall session, whatever we were able to get from our students, we are able to convey to you. Any changes, please let us know in the comment box. Thank you so much for watching. Good night to all of you.